Good afternoon, everyone. I'm Ellen Lautenberg, a board member at the Institute for Climate Change, Environmental Health, and Exposomics, and I've had the privilege of being involved with Mount Sinai's environmental health work for over a decade. It is such an exciting time to support this research. Mount Sinai has always been a leader in environmental health, particularly as it relates to children's and workers' health. Dr. Robert Wright, who you will hear from today, and his colleagues are making research breakthroughs at a rapid pace. The breadth of diseases studied is incredible, from autism and obesity to infertility, cardiovascular diseases, and cancers. They are able to make this progress because of new technology, tools, and methods, many of which are developed at Mount Sinai labs. This new science is called exposomics, or the study of the exposome, which is the totality of environmental exposures over a lifetime and how our biological system responds. Scientists can now take a wide lens to look back in time to understand the mixture of exposures from years past. Things such as chemical exposures that occur in utero, air pollution in our neighborhoods using historical satellite data, including wearables that can shed light on real-time exposures related to pollutants, noise, and heat. Nutrition, social, and lifestyle factors also matter. Today's webinar will explore the environment and age-related diseases. If we can uncover what plants the seeds for disease later in life, we can make progress towards prevention. We are thrilled to have two distinguished speakers with us today. In addition to Dr. Robert Wright, who is the co-director of the Institute, I am pleased to introduce Dr. Sean Morrison, the Ellen and Howard C. Katz Professor and Chair in the Brookdale Department of Geriatrics and Palliative Medicine here at Mount Sinai. Dr. Morrison, please take the stage.
Thank you, Ms. Lautenberg, and thank you so much for inviting me to your afternoon party today. Let me just share my screen, and then I'll walk you through a little bit about what I hope to accomplish in the next 20 minutes or so of a formal presentation. So I want to talk about longevity and environmental exposures, and I'm going to do this in three ways. First of all, I'm going to talk a little bit about why longevity matters now, particularly in 2024, and the real changes that we've seen in human longevity over time, and why, as a population, I think my field of geriatrics has become so important. We're going to talk a little bit about the contributions of the environment, both to quote unquote what people describe as normal aging and quote unquote the health span, and I'll just define that in a little bit, but also the impact on disease and how environmental exposure impacts our risk of developing common diseases. And then finally, I want to talk a little bit about the particular challenge of Alzheimer's disease and related dementias, because it's something that I think many of us fear. It's a disease that we don't have good treatments for now, and it's a disease that more and more and more we're beginning to understand that environmental exposure has a much greater role in its development than we thought previously. So let me begin, however, by putting the discussion of longevity into a little bit of context, particularly context within human evolution. And what I've plotted on this slide is average life expectancy from the time that the first human beings crossed the Bering Strait into Alaska and North America, somewhere on the order of 20,000 odd years ago, probably plus or minus a decade, up until 2024. And what I want to point out to you is that life expectancy in North America and in New York City stayed very, very flat. it was absolutely no change, somewhere between 30 and 40 years for almost 20,000 years. And it is only very recently, within the past 120 odd years, that we have seen this dramatic increase in life expectancy, such that the average person in the United States can expect to live to 78 years. A little more if you're a woman, a little less if you're a man. And as our longevity has increased, or our lifespan has increased, we've also seen a dramatic change in the diseases that we die from. As little as 125 years ago, the 5 leading causes of death in the United States were pneumonia, influenza, tuberculosis, dysentery. Top 3 were all infectious diseases, followed by heart disease, stroke, and liver disease. And 40%, think about that, 40% of all deaths occurred in children. If we fast forward to this year, and the preliminary 2024 data, the leading causes of death in this country are almost all chronic diseases. Heart disease, cancer, accidents, and the major cause of death from accidents, motor vehicles, illicit opioids, and firearms. Stroke, chronic lung disease, Alzheimer's disease, and less than 0.15%. That's not 15%, that's less than 0.15% occur in children. What that means for most of us is that that time after the age of 65, when we typically retire, is going to be a time of relatively good productivity, time for reflection on our past life, time for making better connections with our family, time for continuing to work. And at some point, all of us are going to develop one or more chronic illnesses, which we will live with for many years before we die. And I say that because if we can reduce our risk of developing one of these chronic illnesses, at the same time that we increase treatment or effective therapies for them, the time that we spend in good health can potentially increase. A tangential note here, and I think this is really good news for us as a population. In 2024, for the first time, COVID-19 dropped out of the 5 leading causes of death in the United States. In 2020, it was number 2, and in 2021, it was number 2. Not only are we living longer, but there are a lot more of us living longer. This is what's classically described in my field of geriatrics as the squaring of the age pyramid. And what these figures show is on the x-axis, the bottom, is percent of the population. Males are on the left, females are on the right. And along the y-axis, the vertical bars are the percentage of people within each age group. And what you can see is back in 1900, the overwhelming majority of the population was less than 35. In 1970, we start to see a big change, and that continues up until 2030. By the way, the light blue bars are the baby boomers, the last of whom will turn 65 in 2029. And what will happen in 2030, for the first time in all of human history, is that the number of people over the age of 65 in this country will be greater than the number of people under the age of 21. So we have not only a group of people who are living longer, but there are a lot more of them, and there will continue to be a lot more of them. Now, what does this have to do with the environment? And what does this have to do with healthcare? When I ask medical students or even physicians, and I ask them, what was the singular reason or what was the major reason that life expectancy is, twice what it was in 1900. And what I hear overwhelmingly from folks is it's one of two things. It's modern medicine and antibiotics. And the reality is, yes, those help. But what doubled human life expectancy was clean drinking water and vaccines. If you look back at 1900, and this is sort of a picture of the most major advances in healthcare up until about 2017. But if you look back at the 1900s, average life expectancy was about 48. And by 1951, it was 70. If I do the math right, that's 22 years gained. And what happened during that time? Well, we started chlorinating drinking water. We started treating sewage water and sludge and wastewater. And we started making sure that cities had sewers. We started vaccinating people. 1923, diphtheria, whooping cough vaccines. And those two major interventions, public health and antibiotics, brought us 22 years. Antibiotics, which come into routine medical practice in the 1950s. They were first made available to the public in 1945, but they really didn't come into clinical practice until the mid-1950s. Cancer chemotherapies, hypertension therapy, monoclonal antibodies, everything that we associate with modern medicine buys us about 8 years. And as the New York Times reported, I guess it was last week, but there's been now a series of papers that basically have shown we're not going to increase life expectancy anymore. We truly have. The question is, have we reached peak human lifespan? The answer to the question is yes, we have. And so should our research efforts be focused on continuing to see how we can increase human lifespan? I think the answer to that is probably no, particularly given what we know about chronic disease in older adults. And my bias is that rather than focusing all of our efforts on making us live longer, perhaps we should be focusing on helping us to live well and helping us live with the best quality of life for as long as possible. And that brings me into longevity. And the question is, how can I, or what can I be doing to increase my longevity and my health span? Well, the first thing you can do is to pick your parents. Because no matter what happens, genetics plays the strongest role. And your genes are going to determine what happens to you. So pick your parents really, really well if you can. The second, and it goes without saying, but I will say it over and over, is that the most important thing you can do to live longer and better is to make healthy lifestyle choices. And the data on this are overwhelming and crystal clear. Exercise, don't smoke, get good night's sleep, get good rest, and if you want, don't drink. The data on alcohol are now pretty clear that alcohol is associated with cancer. I love my glass of wine with my dinner, and I am more than willing to make that choice. But if you truly want to live as long as possible and as well as possible, alcohol is not on the things that you want to be drinking. And I honestly, and Bob Wright has really sort of shifted my thinking on this considerably the more I learn about this, is that the way that we're going to increase health span is probably not through pharmaceuticals or drugs. It's probably not through new innovation around therapeutics. But the best way we can do this is to reduce the exposure that we have to bad and toxic things. And I want to extend that argument a little bit. This is a relatively complicated figure that I stole from an article in Geroscience that starts to put the effect of, or look at the impact of the exposome on aging. And what this sort of tree does is puts together the fact that all of us are going to age. Our heart is going to age, our brains are going to age, our blood vessels are going to age. And even if we don't develop any form of illness, we will age. We will get older. And at the same time, those mechanisms that predispose us to normal aging can also, when they get impaired, lead to disease. And diseases such as cancer, heart disease, stroke, arthritis, Alzheimer's disease. And that's what we see when we look above the ground. When we look at actually the roots of all of this, what we're looking at is a series of very complex micro and macro molecular mechanisms that both lead to normal aging and at the same time, if they are impaired or disrupted, lead to disease. And it is environmental toxins and pollutants that we are learning more and more have the biggest impact on these very, very important cellular mechanisms of both normal aging and disease. And I want to just take a moment to give you some examples of that. So let's look at, for example, cardiovascular and cerebrovascular or brain disease, stroke. In red boxes are the key components, and I'm not going to go through what all these are because some of them even I don't understand. No, it's not quite true. But these are the key components that are both associated with cardiovascular aging and which are disrupted by environmental toxins. For example, the fine particulate matters in air pollution accelerate atherosclerosis, hardening of the arteries. They increase the risk of heart disease, ischemic heart disease, and they increase the risk of stroke. If you're exposed to burning diesel fuels, gasoline fumes, burning wood, plastics, all of those, and even frying your fatty foods, all of those can release a compound called acrolein, which damages the heart muscles and the blood vessels in the heart. You know, we have seen, and I wish Flint wasn't such a terrible example, but we've seen what happens that our groundwater is not as safe as it should be or we'd like it to be. And the contaminants that we see in our groundwater, arsenic, cadmium, mercury, and organic pollutants, all have been found not only to increase our risk, but accelerate our risk of cardiovascular disease. What about cancer? More and more, the data are demonstrating that environmental pollutants increase our risk of developing cancer, the second leading cause of death in the United States. Outdoor air pollution, again, fine particulate matters increase our risk of lung, breast, and bladder cancer. In middle and low income countries where people burn wood and other solid fuels for cooking, significantly increased risk of oral, cervical, and esophageal cancer. I will not go through all the chemical exposures that one can see in the workplace or at home, but there are a lot of them, and I've color-coded them to line up with the different cancers that we know these increase the risk for. I do, in fairness to my wife, who has forced and has bought organic food for as long as it's been available, the link between pesticides and lymphoma. So if you can, buy organic. And I know we all know this. I'm going to say it over and over again. Sunscreen, 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 because UV radiation dramatically increases our risk of melanoma and other but non-fatal skin cancers. COPD. We always think about COPD as a result of smoking. That smoking is the overwhelming risk factor for COPD. Yes, and outdoor air pollution also increases our risk of COPD. Burning solid fuels, again, dramatic increase in the risk of COPD, accounts for, in some estimates, 25% of deaths from COPD in low to middle income countries, and a number of occupational exposures and occupational environments. The chemicals in that found in them increase our risk of COPD. And again, it goes without saying, it's not just smoking yourself, but it's being also exposed to tobacco products, what we call secondhand exposure. Cohabitant smokes, back in days of yore in New York City, going into restaurants and bars, secondhand smoke is clearly a risk factor for COPD. And finally, although it doesn't show up as a leading cause of death, I might argue that some of the greatest suffering and limitations of daily activity comes from musculoskeletal disease, arthritis, and osteoporosis. And again, notable environmental factors that affect the cellular mechanisms that both lead to or can be impaired by, that lead to musculoskeletal disease, or if are impaired, accelerate the development of osteoarthritis. And again, outdoor air pollution, indoor air pollution is really bad for your bones. Lead, I know Bob, this is Dr. Wright's, one of his many areas of expertise, but he's always on me and he's right. Lead is bad, 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 bad. It's bad for kids, it's bad for adults, and it's bad for older adults. It reduces your bone density, increases your fracture risk, and disturbs bone remodeling that often doesn't reverse. Pesticides, again, decrease your grip strength, result in muscle weakness, and also alter neuromuscular function. And a number of specific chemicals have been associated with autoimmune disorders, particularly rheumatoid arthritis. That's what RA stands for. Let me just pause and say I'm tired of gardening and I'm going to move away from trees. And let's talk a little bit about Alzheimer's and related dementia, because this is, I think, one of the real hidden healthcare threats that we're facing as a nation. Alzheimer's disease and related dementia is a brain disease. It results in disturbances in memory, and as it progresses, other forms of cognitive function. And it's a disease which is increasing at a fairly rapid rate, both in the United States and worldwide. In 2020, about 6 million Americans were diagnosed with Alzheimer's disease. That number is going to grow to almost 8.5 million by 2030, and it's basically going to double by 2040. Most develop Alzheimer's disease over the age of 65. Peak onset is in the late 70s, early 80s. But remember, average life expectancy in the United States is 78. That means 50% of us are going to live longer than 78, half of us. And by the time we reach age 80, 1 in 3 of us will have developed Alzheimer's disease. That by age 80, the risk of developing Alzheimer's disease is going to go up to 20 to 30% through your 8th decade. So it's something that it's a health crisis. It's something right now we don't have any treatment for. And I would be lying if I said I was really optimistic that there was something right now in the scientific pipeline that's going to reverse this disease. We've got a number of drugs, one of which was developed here. Dr. Davis developed galantamine, the acetylcholinesterase inhibitor. At best, folks, they result in very, very, very modest reduction in the decline of cognition. Doesn't return cognition to normal. It just means it doesn't go quite as quickly. We've got another drug, memantine, that may delay nursing home entry for people with advanced disease. And I underline the use of the word may. There's been a lot of press about the new monoclonal antibodies that have come out that dissolve amyloid. Amyloid is an abnormal protein that shows up in the brains of people with Alzheimer's disease. And these drugs are fantastic amyloid dissolvers that you're infused with these drugs. You have to stay on them monthly. The amyloid plaque in your brain melts away. The problem with that, though, or the problem is that even though your brain is pristine and looks normal now on your PET scan, it doesn't really change the progression of disease. That we see very minimal, at most modest slowing of cognitive decline. And that's with associated side effects of brain bleeding, infusion-related reactions, headaches and falls, and the requirement for monthly infusions and regular monthly MRIs. And we've studied a lot of drugs and haven't shown them to be effective. But, if we look at the risk factors for Alzheimer's disease, and we exclude genetic risk factors, because none of us, unfortunately, can pick our parents, 45% of risk for Alzheimer's disease is potentially modifiable, either by individual action or by societal action. And what I want to point out is that there are a number of exposomic factors that considerably increase the risk of Alzheimer's disease. Being socially isolated. We'll talk a little bit later about some of the threats of climate change and the increase in social isolation. Air pollution, excessive alcohol use, smoking, hearing loss. And, one of the things that really strikes a chord in me is that hearing aids have a better effect on Alzheimer's disease treatment than do all these fancy drugs that we have. But if you think about looking at these risk factors, if we did something about any or all of these, we could reduce your risk of developing this devastating disease 45%. What about the environment and Alzheimer's disease? We know that air pollution is associated with increased dementia incidence, particularly those who carry the ApoE4 gene and already are at increased genetic risk for this disease. This includes nitrogen dioxide, the fine ambient particulate matter I talked about earlier, traffic exhaust, residential wood burning. We know that people living in metropolitan areas, New York City, unfortunately, have an increased prevalence of brain structural and chemical changes associated with Alzheimer's disease. And a number of those cellular mechanisms underneath in their roots are affected by environmental toxins that increase the risk of Alzheimer's disease. And if we expose mice to air pollutants, I'm afraid we replicate those findings and unfortunately develop demented mice. We also know that exposure to fine ambient particulate matter is associated with impairments both in our ability to immediately recall things and new learning. And I'm convinced by these data, and the Lancet, which is one of the most respected journals in medicine, is convinced of these findings. Hearing loss. Hearing loss is associated with a near twofold risk for Alzheimer's disease. in people followed over the age of, or people followed middle age and followed for 9 to 17 years. So for those of you who have hearing loss, and those of you who have members in your family who may have hearing loss but are perhaps resistant to hearing aids because of stigma, it is not just a quality of life issue. It is probably the most important thing you can do to prevent the development of dementia is to get a hearing aid. And in fact, the risk of Alzheimer's disease increases for every 10 decibels of uncorrected hearing loss. We see this in people who develop midlife hearing impairment. We see that subsequently they have brain structural changes that are associated with dementia. And importantly, if you get a hearing aid, we find that it slows the delayed recall associated with Alzheimer's disease. It changes the course of the disease. There's some really interesting work, preliminary work, that suggests that traffic noise may be associated with Alzheimer's disease. The problem is that if you have areas with lots of traffic noise, you also have areas with lots of air pollution. So it's hard to tease those out. But we are very much aware that noise exposure leads to hearing loss. It's one of the major risk factors for hearing loss. And we know that hearing loss is associated with the development of Alzheimer's disease. So I really, really worry about noise pollution. I really, really worry about everybody that I see in the subway with hearing aids, iPods, blasting music that I can hear. And I really worry when I'm walking down the streets about the people riding in cars with very, very loud music playing. And our road models, our mouse models, suggest that chronic noise exposure truly does result in Alzheimer's dementia like neuropathology. And climate change, and I'm going to end my talk on climate change. One of the things that happens as we age is that our ability to compensate for extremes in temperature decreases. We don't sweat when it gets hot, we don't shiver when it gets cold, and we don't feel thirsty when we become dehydrated. And those are normal age-related changes that we see in how our body regulates itself. These abnormalities, and I wouldn't even describe them as abnormalities. I should not have used that word. I was looking for the right word and couldn't find it. These normal changes in thermal regulation that we see with aging are much more impaired in people with dementia. And if you think about it, people with dementia may not remember that they were thirsty an hour ago and need to tell you about it, or may not remember to go inside because it is so hot, or may not remember to turn on their air conditioning. We've seen heat stress associated with decreased cognitive function. We have some preliminary data that suggests that people with dementia are at significantly increased risk of hospitalization during periods of extreme heat, and that they're at significantly increased risk of death or injury because of extreme heat events. And I do worry in so many ways about not only climate change impact on our kids and our future, but also the immediate effect about older adults right now. And so I'm going to leave you with some unanswered questions and unanswered empirical questions that I think we need to focus on answering right now. If we are going to be able to truly increase our health span, that is the time that we spend without cognitive impairment, without functional impairment, with the best quality of life for the time that we have, typically over the age of 65. So I think we need to know what are the contributions of exposure timing, how long do you need to be exposed, and what's the intensity of exposure on age-related diseases and conditions. It's unrealistic to say that we're going to eliminate gasoline-powered internal combustion engines, but how much do we need to reduce risk? What is the risk of short-term exposures on adverse clinical outcomes, and also on hospitalization, emergency department visits, healthcare costs. What's the relationship between ongoing risk exposure and disease progression? If you have a specific disease, cardiovascular disease, COPD, how much are you going to put yourself at risk if you have ongoing to exposure? And one of the things I'm really, really personally interested in, what's the role of noise exposure on sleep disturbances? Because the more and more data that we have suggests that sleep and good sleep hygiene and habits are critically important for both longevity and health span. And to the extent that we're living in a world of sleep disturbance, I think we need some better data on what the effect of those outcomes is going to be. And then finally, I can't conclude with coming back to the impact of climate change, particularly given the past month in Florida and the impact on older adults. The bottom left-hand corner is the nursing home evacuation for a long-term care facility in Florida. What about all of those people living at home who didn't have access to the staff in the bus to evacuate them? What about the people who don't have access to air conditioning? Lots and lots of older adults who, because of their finances and because of the fact they're living on Social Security, which does not meet their needs, they don't have access to air conditioning during these heat extremes. Anybody with a gait disorder walking down that picture of Buffalo in the middle of winter last year, who may need a cane or may just be unsure of their feet, the risk of a fall and a hip fracture is dramatic. So I think this is something, as healthcare professionals, we really need to think about and tackle because of its impact on population health. And let me stop there, say thank you. And I think, Ellen, I turn it back to you now, right?
Yes, I'm going to quickly thank you so much. That was incredibly fascinating. I'm just trying to digest a lot of that, but it was amazing information. And I just want to very briefly kick it back to Dr. Wright to just put that in context very briefly as to, in terms of studying the environment. And then we are going to, I believe, extend until 12:50 so we can get some questions in. And so I will now turn it over to Dr. Wright.
Thank you, Ellen, and thank you, Sean, for that was a fantastic tour de force of the relationships between environment, the exposome, and aging, particularly dementia and Alzheimer's disease. There are so many unanswered questions that it is sometimes challenging to just know where to begin. I'm only going to briefly talk about one additional aspect of how environment impacts aging. It's a concept that some of you may be familiar with called the developmental origins of health and disease. And that's that the environment we experience as children or even young adults actually has a major impact on our life and our health as we age. And one of the areas that I think we may see something in terms of even more increased rates of Alzheimer's disease and related dementias than expected is the role of childhood lead poisoning. So, for example, many of you know that there was lead in gasoline up until 1989. There was lead in paint up until 1978. And I would bet that the large percentage of you, if not the majority, were children back in the 70s and 80s, which means you were exposed to lead. That is not happening to today's children, thankfully, at least not at these levels. But because there is a relationship between what happens to you as a child and what happens to you as an adult, we may actually see an increase in Alzheimer's disease above what's expected because the people who've developed Alzheimer's disease over the last 20 to 30 years were not exposed to lead at those levels. So even though lead may have been in gasoline in the 1930s and 40s, there were far fewer cars and far fewer roads, so the exposure levels were modeled to be much lower than they were in the 50s, 60s, and 70s. So lead exposure really peaked in the 70s, and that's where many of us were children. So we may actually see some long-term effects of that on Alzheimer's disease and related dementias. One of the reasons why that happens is your brain develops as a child. So your brain, when you're a fetus, your brain is making 250,000 neurons a minute, and it creates the network that becomes your thought processes. And that neural network is actually the framework under which neurodegenerative processes from either genetic susceptibility or air pollution or other types of toxic exposures occur. So that's why the things that happen to you as a child are so important, because the things that happened to you as a child built that network, and it confers some degree of susceptibility or resilience to environment from that point afterwards. Another potential troubling sign is child obesity. So obesity has been associated with Alzheimer's disease and dementia as well, and obesity has skyrocketed in the last 30 years. So there may be an intersection in the 1980s actually of children who are exposed to lead and have higher rates of child obesity, and that may also unfortunately portend future even higher rates of Alzheimer's disease. So it is something that's very concerning and something that I think we need to do more research on to sort of understand what the implications are of those childhood risk factors on future diseases of aging. So I'll just stop there. I just wanted to throw out, in part because I'm a pediatrician, the role of environment as a child and how that might affect aging.
Critically important. Our brains are continually developing, and yes, that early impact.
And we do have a couple of questions. Thank you so much, Dr. Wright, for your insights related to that. And I just want to see if we have time for a couple of these questions. So, 1 second. Okay. Regarding the relationship between hearing loss and Alzheimer's, is this risk the same in someone born with hearing loss? Or is there something about the neural mechanisms in which auditory signals are processed that places an individual at risk? Or is hearing loss a proxy for another exposure later in life? That's a pretty hefty question, but hopefully you can address that.
Let me tackle it 1, 2, 3. We don't know yet. We don't have the science to determine whether people who have born with hearing loss or even develop it at childhood have an increased risk, and those are studies that need to be done. The second question is, the second point, which is actually the answer to the third, is we suspect, or at least the data suggests, that hearing loss truly is an independent risk factor. That is, the hearing loss itself, that the hearing loss is not a marker for something else. And the evidence for that comes both in the epidemiological studies and also the fact that a hearing aid, improving hearing loss, reduces both the subsequent risk and improves cognition.
Okay, thank you very much. Another question here. What do we know about how early life exposures in the prenatal period to noise can affect health? Are there specific types of air pollution that are most detrimental to neurodevelopment during that period?
I'm going to turf that one to Dr. Wright because he's the pediatrician here.
That's a great question. There's two types of hearing loss. There's conductive hearing loss, which is affecting your eardrum and how sounds get transmitted from there to your brain. And then there is neurologic hearing loss, which is the neurotransmission of those signals. So there are environmental chemicals such as mercury and lead that actually affect more the neurologic hearing loss and less so the conductive hearing loss. Most noise, I believe, is conductive. But when a brain is developing and your hearing system is developing, what it's really doing, it's reacting to environmental signals. So there are environmental signals that actually direct the neurons to form and direct them to form a network. And so very loud noises would presumably interfere with normal processing, just as the absence of any sounds whatsoever would actually cause the regression of neurologic networks. We definitely see that with vision. If you patch an eye, you lose actually the neurological networks. that actually occur. In fact, if you patch an eye in, say, a newborn kitten, and this is some studies that were done in the 1960s, you can actually, after they've actually developed a neurologic network, a newborn kitten, if you patch its eyes, the network regresses, whereas an adult cat, if you patch the eye for the same amount of time and the network is formed, it doesn't regress, which is sort of an example of why an environmental factor when you're developing is so much more toxic, because your body at that point is looking for signals in order to develop the neurological network, whether it's vision, whether it's hearing, or whether it's learning. It's reacting to stimuli, and that's why reading to your child is so beneficial for brain development, and sort of social isolation is so toxic to brain development. So it's actually the response to the environment that's actually driving development, and that's true of almost every type of neurologic system, whether it's hearing or vision or learning or other types of systems.
Okay. Wow, that's fascinating. Another question. Do individuals who are thought of as highly educated or higher functioning, for example, physicians, have more of a reserve when it comes to cognitive decline? And is it harder to pick it up in individuals with more education?
Two questions. The first is, what we do know is that people of higher education have a lower risk of developing Alzheimer's disease or related dementia. And certainly, and that goes back all the way to early childhood education. So we know that there is a clear independent link between education and the development of Alzheimer's disease, and that may well be because of brain development. And so, yes, there may be more reserve. The second part to the question is, it is harder to pick up cognitive impairment in people with a higher education level with routine screening tests. However, for people with higher education or higher cognitive function, they often are aware of changes in their cognition, and that is the point to refer to a specialist, either a neurologist with a specialist in Alzheimer's disease or a geriatrician for more sophisticated testing, because even though there's not terrific drug therapy, there are interventions that can certainly be effective and help. And I just come back to my hearing aids again and again and again.
Great, thank you. And then our final question here. What measures are being taken to educate healthcare professionals regarding the adverse health effects from these toxic environmental exposures? I know that's kind of a giant question, but if you can synthesize it down to the next minute or two, in just top level. Thank you.
That's Dr. Wright, because that's what his department is doing. I mean, seriously, there is a department here, and that's the reason for it.
Yeah, that's a hard question, because the medical education system is really big and it operates on different levels. There's medical students, there's residents, there's physicians, there's also nursing and other healthcare providers, physician assistants, and nurse practitioners. And medicine has gotten extraordinarily complex. The average physician visit is about 15 minutes. So you can imagine that there is understandable hesitancy to take on additional educational initiatives. I think if we are to break that barrier, we need to figure out ways to simplify how physicians and healthcare providers, whether it's nurses or PAs or nurse practitioners, we can get them the information, synthesize it for them, and provide it for them in an easy fashion. Expecting them to go out and learn it, I think, is probably too tall an order. And I think what we really need is an infrastructure in the medical education system to make this simpler for healthcare providers to give to their patients, because right now it is admittedly complex. So I think it's going to involve a lot of investment, although I think it is possible. We're starting to see it in genomics, where there, genetic counselors now exist that try to synthesize genomic information and provide it to patients. I think it should be a goal of environmental medicine and exposomics as a field to do something in parallel, where we try to synthesize information at the individual level and provide guidance as to what it means for a patient and what they can do about it.
Okay, great. And as we're wrapping up, can you comment briefly on what lifestyle changes or environmental changes can someone at any stage of life, younger, middle age, make to reduce their risk? I'm sorry, that's the wrong. I apologize. That's a deeper question. Can you give some examples of research opportunities on aging and environment and things that you might be excited about so that we can end this on a positive note?
I'll give that one to Sean.
Oh, I was going to give that one to Bob, but I think there's some really important things that we can do. I want to come back to climate change and health, because we do, first of all, it's understanding who is at risk, who is at higher risk, so we can develop policies to address that. Number two is we have to do something about this. And it's no longer theoretical, it's real. And it may be one of the biggest factors in terms of preventing us from increasing our health span. And then three, I think there needs to be a lot of work done on tightening up our understanding around exposure to pollutants and their effect on both normal aging and accelerated aging and disease, because those are things that we can do something about with public policy and regulation. As Bob said, lead is both the great example of success and a great example of a failure. And we need to have those very tight scientific links so we can make those appropriate policy decisions.
Okay, great. Thank you so much. So we are going to wrap up, and there will be an email sent out to the people who watch this with a recording, as well as any extra questions that were left over, perhaps in response to those questions. So for now, I would like to thank our panelists and everyone who joined today. Our institute is not just doing research, we're working with parents and leaders to build healthier communities. I encourage all of you to stay connected and help support this critical work. Please fill out the evaluation form. There is a link in the chat, and please feel free to get in touch with us to get more involved. Thank you, everyone, again.
Yeah, thank you, Sean, in particular.
Well, thank you. Thank you. It was a real pleasure. I really appreciate the time.